Okay, so we are here at EHA and we just heard yesterday some very interesting simultaneous on Hodgkin lymphoma. Dr. Casanovas presented his results on the AHL 2011, which was a PET-driven therapy versus a not PET-driven therapy. What they found is that 87% of the patients were PET negative, and in this group of patients where the de-escalation was performed, they had the same event-free survival and than the standard arm. So basically what we're seeing, the same as in other different trials, is that it is safe to de-escalate therapy in patients who are PET negative. So this will, in the future, probably bring less treatment-related toxicity. For those patients who are PET positive, this is an adverse prognostic factor. So patients who were PET 2 positive and PET 4 positive was the group that did worst. And there's a subgroup of patients that were PET 2 positive and PET 4 negative. And these patients had an intermediate overall progression-free survival. So this is very interesting. We are seeing again that we can de-escalate in this group of patients. So we have the opportunity to choose which group of patients can benefit from less intensive treatment without changing their outcome. The German study group also showed a very interesting retrospective analysis, and I will just summarize it very quickly. But what they showed is that having a vitamin D deficiency at the start of therapy was a very relevant PFS prognostic factor. So they talk about stationality, so patients, in wintertime, patients diagnosed in wintertime had lower vitamin D levels, and these patients had a worse prognosis. So this is very interesting because there's a big gap between patients who had vitamin D deficiency or not. So what we don't know yet is if we give these patients vitamin D through treatment, whether this will change the adverse prognostic factor. But this was really very interesting because it was a big difference between those who did or did not have vitamin D deficiency. Dr. Martin Hutchings also presented something that we saw in the first part last ASH, which are the results from the Echelon 1, which showed a better modified PFS for patients in advanced stages 3 and 4 that were treated upfront with VV plus AVD versus AVVD. And here we just saw a subgroup analysis, and basically what Martin Hutchings showed is that the subgroup with stage 4 or with more than one extranodal disease site had a better benefit on modified PFS and PFS. So the higher the risk of the patient is, the better we do by adding brentuximab up front. And last, the Spanish group by Dr. Ramon showed their experience with brentuximab plus EHA, which is their commonly used salvage regimen for patients who relapse, and they showed the combination of brentuximab plus EHA as a salvage therapy for patients who transplant and as a bridge for patients who relapse, and as a bridge to transplant. And what they showed that the toxicity was no more than what was expected, that this is a feasible treatment to do, and that progression-free survival after transplant was 71%. I think so. This is also a new option we have to include brentuximab in addition to chemotherapy as a salvage therapy bridge to autologous stem cell transplantation. So we are full of new options and full of combinations, and in different, both in first line, in salvage therapy, and for relapse after autologous stem cell transplantation with incorporation of these new drugs.